Now, please welcome White House Advisor, Chairman Thomas Philipson, Council of Economic Advisors, in a conversation moderated by Ovik Roy, President of the Foundation for Research on Equal Opportunity.
And I've been taking care of business every day, taking care of business every way. I've been taking care of business.
Gotta love this intro music. Well, Tom, you are chairman of the Council of Economic Advisors, the premier economic R&D shop at the White House. It's kind of an important job. What's your take on the economy right now? How would you summarize the Trump economic agenda?
Well, there's basically several pillars to it. One is the tax reform that took place in December 2017, which has spurred a lot of labor demand, and workers' wages are going up and employment is going up as a consequence, and we're currently at the lowest unemployment rate of 3.5% we had in 50 years. Then there's the international trade negotiations, which essentially tries to neutralize how we get treated abroad with how we treat others. We treat others a lot better than we are treated abroad in terms of opening up markets. So those negotiations are obviously ongoing. We have reached an agreement with Japan, South Korea, and we're in a phase one of China. The third pillar, which is energy independence or promoting innovation and production in U.S. energy. And the fourth pillar, which is more relevant for this conference, I think, is deregulation, which is kind of not discussed as much. So the Trump administration in January 2017 instituted, almost the first day in office, a very aggressive deregulatory agenda. So if you look at the number of new regulations under the administration, they basically dropped to zero, and a lot of other regulations that were in place have been knocked off the table to a point where we actually have deregulated a lot more than the sort of golden era of deregulation under Reagan. So I think those are sort of the four pillars of our economic policy.
One area where you've tried to use regulatory reform as a tool is in prescription drug pricing. Tell us about where that stands right now. You've had a lot of regulatory initiatives around trying to reduce the cost of prescription drugs in the U.S.
Yeah, so there's a couple of things going on. Before the administration, prescription drug prices were going at an annual rate about 3.6%. They have now been declining the last 10 months on an annual basis, 12-month trailing average, and have gone down for the first time in also around 50 or 60 years, which is a great sort of development. Part of that is deregulation, so that fits into the overall economic agenda, meaning FDA was pretty heavily deregulated in terms of generic entry under Scott Gottlieb and going forward as well, either through guidance or procedures. So what you saw, CEA, Council of Economic Advisors, where I work, estimated that about 136 at the time more generic firms were on the market because of this deregulation. So that's a sort of a classic example of deregulation leading to more competition, leading to lower prices, which is sort of the purpose of a lot of deregulation, is to stimulate competition. Now, overall in healthcare, or in drug pricing in particular, I think the key issues are really government barriers to appropriate price competition. So for example, both in Part D and Part B, we essentially subsidize high prices. Part B by paying doctors more when they prescribe more expensive drugs, which is not a great way to have a demand side that like higher prices. And Part D by having heavily subsidized the high-cost individuals. So you have a system where essentially a third party is paying for the high prices that are taking place, and therefore doesn't discipline the market as much. On top of that, you have reduced competition dramatically through appropriate but too stringent, in our opinion, FDA policies, where it takes a decade or $2 billion to get on the market. So you can imagine if that took place in telemedicine or in telecommunications or software, what that market would look like if you had those kind of entry barriers. So very high subsidies on the demand side that takes care of the high prices, and then very high entry barriers on the supply side is not necessarily surprising that we have such high prices as we do in the U.S.
I should mention that before you joined the CEA, you were an economist at the University of Chicago, where prescription drug pricing was one of the areas of your academic focus. There's another area that's related to pharmaceuticals, but in a different way, which is the crisis around opioid prescription drugs and opioids in general. The Trump administration's been trying to do a lot there. How does that fit into the deregulatory agenda or the broader economic agenda of the White House?
So CA estimated before, pre-Trump, that the crisis essentially was costing the U.S. about $500 billion a year. Most of that was in mortality. So if you take standard ways in which the government assesses the economic damage or mortality, that's the biggest part, where we currently at the time had 70,000 deaths a year. That's been mitigated, and we're now turning around essentially in the death toll from overdoses, not only prescription, but also other types of drugs. And we have estimated at CA that relative to the previous trend, about 30,000 lives have been saved from that turnaround. Part of that is the Support Act that the Trump administration and Congress implemented, which was the largest effort ever in terms of spending to fight a drug crisis in the U.S. Now, in terms of government issues involved in the opioid epidemic, I think it's very, very important to realize that this was a highly subsidized epidemic by the government. So what do I mean by that? Essentially, if you were an addict, as CDC defines an addict, you have to consume a lot of pills of opioids during the prescription part of the epidemic, which was sort of led into the current part of more illegal drugs, to a point where it would cost you about 50 grand a year to keep up an addiction if you paid it out of pocket. Mainly because you're obviously consuming a lot of pills. It's not like us when we go to the pharmacy and we have a copay once a month. This is a lot of pills being consumed to keep up an addiction. So that would not be affordable by most people. So what happened was that Part D, Medicare, subsidized the fraction of pills that were paid for by the government went from about 16% to 2/3 during the growth of this crisis, until we started realizing that there was a crisis. Now, obviously, that was not the only force that drove it, but it's also a very important force, which I don't think people think about. It's essentially we subsidized an addiction as opposed to for cigarettes, alcohol, etc., where we tax addictions quite heavily or tax those substances. In this case, we were actually subsidizing it. So the real issue becomes, how do you basically subsidize the medical use of opioids as opposed to the non-medical use, which had to do with addictions? And that's what we're trying to grapple with right now with the safe prescribing initiative by the administration and other measures that we're taking.
You had mentioned, when we were talking about prescription drug pricing, the perverse incentives of Medicare that actually pays doctors more, like a real estate broker, for prescribing a more expensive drug. And that's one of many examples in the Medicare program about how Medicare rewards hospitals, doctors, drug companies for developing more expensive remedies rather than less expensive ones. You have a new initiative. The president issued an executive order earlier this month about Medicare specifically, about expanding choice and reducing cost. What are some of the important takeaways from that executive order you think would be important for this audience?
Yeah, so the Medicare executive order, which is in very stark contrast with some bills that are in Congress, Medicare for All, which are essentially socializing about a fifth of our economy. And it's a contrast in the sense that those bills are being sold as free health care. Another way to state what free health care is about, in my opinion, the correct way to think about it, is it essentially boils down to a tax-financed government monopoly. And a tax-financed government monopoly, we have predicted at CEA, will be far more expensive than current premium levels, so that your premiums will go down a lot less than your taxes and other sort of distortions caused by this massive spending program were to take place. So it's important here to keep in mind that it's not only the 36 trillion which people talk about of Medicare for All, which is actually an overestimate relative to, because we have a lot of current spending obviously in the government. About half of healthcare is paid by, it's currently paid by Medicare and Medicaid. More importantly is what economists call the excess burden of taxation, which is the burden in excess of the Treasury revenues collected. So if I tax, let's say, an airline ticket by $1 million, the Treasury will collect very little tax revenue, presumably. That doesn't mean they haven't distorted the economy to have people do things that are very damaging compared to having no tax. So that's a burden in excess of the revenues collected. So the 36 billion that people talk about is just the public treasury money needed, as opposed to CEA that estimated that the excess burden to collect that money is about 25 trillion on top of the 36 trillion. So it's a big deal in terms of distorting the economy. Now, how are you going to collect that? And why do we think it's going to be more expensive? Isn't this just taxing rich people to help the middle income and low income? And that has not been the evidence or the experience in countries that have big governments. So in Europe, taxes are much more regressive than they are here, because essentially the tax base of rich individuals is not large enough to generate a big government. So once you go big in terms of government, you many times go regressive. In their case, they rely a lot more on sales taxes and payroll taxes than we do. So we actually have a lot more progressive taxation in this country than, let's say, Sweden and Scandinavia do over in Europe, even though they're held up as role models many times, even though they're shying away or actually dropping a lot of the policies that we are proposing to implement here.
So that's the criticism of the Medicare for All proposal. But what about the Trump administration's agenda on how to make Medicare better from the president's point of view?
Yeah, so the contrast is really between market provided and government provided health care. So a lot of what the Medicare EO is trying to do is to basically promote Medicare Advantage over fee-for-service. Fee-for-service is really almost like a Russian-style type of pricing, where prices are set in the capital of the country for the rest of the country, here in terms of hospital DRGs or relative value scales payments for doctors, and replace that bureaucratic price setting with market-based price setting. And one of the things we do in the EO is basically a collaboration with CEA and the HHS on trying to come up with how can we essentially make fee-for-service rate better reflect pricing in the private market. So think my analogy here is kind of what we're doing for Medicaid drug pricing. Medicaid drug pricing, the private market determines what's valuable or not, and then the government gets to take a 23% rebate off that market price. But it's not the absolute amount that matters so much, in that the private market in that case sets what's more valuable or not, in terms of supply and demand, determining what drugs get valued a lot in the market and which doesn't. So essentially what Medicaid drug pricing does is it keeps the relative prices in the market, but the government gets a cut on the absolute price. And there's discussions now, and there's a report coming out of this Medicare EO which attempts to do that for fee-for-service rate. How do we better make fee-for-service rate be set off what's valued in the market by supply and demand, and those prices getting imported into how much the government pays for those services?
One thing I think about in the context of the executive order is site-neutral payment. So Medicare pays hospital-owned clinics more for exactly the same service than Medicare pays independent clinics. That leads to a lot of consolidation, where hospital systems buy up the clinic because they know they can charge more to the government for doing that. So talk to any Medicare Advantage plan, they'd say that's the #1 opportunity to reduce costs in the Medicare Advantage program would be site-neutral payment.
Yeah, site-neutral payment is kind of an example of why bureaucratic price setting doesn't reflect value in some sense, because, and it generates a lot of distortions, not intendedly. I mean, these are well-intended policies, but essentially by not having the information that the supply and demand side of the market would have. And site-neutral payments is important because, you know, the hospitals will essentially have gains from trade with local or small physician shops who don't get paid as much many times, and therefore there's an incentive for hospital-based doctors or doctor shops to buy up these independent shops because they get paid more by the government. And that leads obviously to more consolidation, and it leads to less competition, and it's not sort of a desirable way to go forward if you believe in sort of competitive market care. Generally, I think the administration is if you want to think of a sort of a common theme, is that competition, if you don't like profits in healthcare, competition is a better way to get rid of it as opposed to having the government try to regulate it away.
One theme in the executive order as well is trying to unlock innovation in how technology can help lower the cost of care. We've had a lot of sessions today, a running theme of which has been, well, we don't do X, say telehealth, as much as we could in Medicare because Medicare doesn't pay for it, and there are obviously new models that both the White House and the Center for Medicare and Medicaid Innovation have been trying to implement in that regard. The EO does talk about this too. Talk to us about the role for innovation in Medicare.
So generally about innovation, the way I think about innovation is essentially that it reduces the price of better health, even though it may many times raise the price of health care. So let me give you an example, which is my favorite example. So if you look at HIV positive individuals before 1996, they could essentially not buy a longer life anywhere on the planet. And then you have medical innovation come in, and today expensive care many times, but nevertheless cheaper ways of buying a longer life now exists, even though it costs more in terms of health care. So innovation many times reduces the price of health no matter what the cost of the new treatment is. And that's an important thing to keep in mind. Likewise, different delivery mechanisms or sort of medical service innovation is sort of the only route we need to, it's not the only, it's the major route that we need to promote in terms of lowering healthcare costs. Healthcare costs in the US, most health economists believe is driven by, not because we use more quantities, so spending is basically quantity times price. It's not because we use more quantity, it's because we have higher prices here. Particularly our doctors are much more highly priced than in other countries, and our hospital service is also most highly priced, many times due again to government barriers to competition. So hospitals, for example, are the way we subsidize medical schools, only about 10% of medical school applicants get in to medical school in the US. Imagine if we let a lot more people in, how much more competition there would be on the supply side of the doctor's market. Likewise, hospitals have many times certificate of need laws on the state level, which essentially have existing hospitals decide whether new hospitals should come in the market. That doesn't sound very pro-competitive. So again, I think the Medicare EO is all about how do we essentially generate more competition through reimbursement that is not so particularly driven towards one form of delivery versus another, including electronic healthcare.
And that should also incentivize innovators to find lower cost ways to compete with those incumbents.
Correct.
Tom Philipson, thank you very much for being with us today.
Thank you.